Hello and welcome to another episode of the Melbourne Athlete Development Podcast. Today, I'm very happy to have Associate Professor Michelle Smith. Michelle, thank you for being here today.
Thank you very much for having me.
So, Michelle, it's always good to start with giving some context of the conversation to give you an opportunity to tell us who you are, what you do, and your current role.
Okay. So I'm originally from Canada. I did my undergraduate physio degree for context in Canada and did my, I don't know, the name of these degrees change everywhere. My human movement / exercise science / physiology, whatever the university decides to call it. I did that degree as well in Canada. And then I did my master's of sports physiotherapy and my PhD here in Australia. So I've been in Australia for, I guess, officially about 10 years now.
What brought you over here?
I actually wanted to specialize as a sports physio, and
Yes,
in
okay.
Canada, it's a bit of a different system. So you can't do like a master's degree to specialize in musc or sports or something like that. And that was
Right.
always something I wanted to do. So interestingly, my head of school, when I went to university in Canada, he was Australian. So he was from WA.
Right. Okay.
Um, and so I guess like in conversations with your head of school, I had a chat that I really wanted to specialize as a sports physio, and he recommended I come to Australia. So that's kind of where it all began, which was, yeah, exciting.
Well, it's interesting. To give you some context, I'm currently doing this 3-year training program, this method called fascial manipulation, which is based out of Italy. So I've been going to and from Italy a lot, and I've had an opportunity to meet a lot of physiotherapists from all around the world. I've actually met none from Canada, a few from the States, different areas of Europe, Asia, Africa. And it's always interesting to see the differences in what people learn and the
Mm.
framework and philosophy of how they work clinically. Do you see similarities between Canada and Australia, or are they quite different? Or
Um, that's an interesting. So there's probably a really good politically correct answer to this question, and probably a bit more of a my perspective answer to
well,
the question.
to be fair, the thing that's really stood out to me with going to Italy and talking to clinicians from around the world is the narrative and the bias we have in Australia, and we
Yeah,
definitely do. And that's not to say that there isn't a lot of great things, great physios and research and perspectives from Australia, but we do also have certain biases or slants towards focusing on certain things and not on others.
yeah. No, I think it was interesting. I like my plan was actually to come to Australia only for 1 or 2 years and then go back to Canada.
And here you
But
are.
like after I graduated from my physio degree in Canada, I started working there. And I like, yeah, of course, like you're a new grad and you're figuring things out and stuff. And there was things I didn't love about physio.
Mm,
And I wasn't sure, like, you guess you figure out where you're going to go, you
yeah,
settle in and
yeah.
stuff. And I did my sports masters in Australia, and then I worked in Australia for a bit, and I liked physio more.
Mm, mm.
And I like part of that could be that I did my master's degree. So you're feeling more confident, you develop skills. But I guess part of the thing that I didn't like, and it's probably unique to my experience, of course, like different people have different experiences, is
Mm.
I think the way I thought physio should be was more aligned with how I was seeing it done and how I had the experience in Australia.
Okay.
I quite enjoyed and where I worked in Canada, I think I occasionally had a few negative experiences with pressures to, run through people really quickly in appointments and
Right.
reliance a bit on electrotherapy, which isn't really my way of treating physio. So
Sure,
I felt
sure.
like Australia was more aligned with what I saw myself as a physio and how I saw the profession in my head. So maybe the
Mm.
Australian biases matched my biases, and then it worked well.
Yeah, well, it's interesting you say that because I certainly have resonated a lot with some of the things I'm learning from this course in Italy. Because yeah, there's certain things that I've really valued about learning physiotherapy here in Australia, but then I see some limitations as well, and I see it being done better elsewhere. But
It's really fantastic for the opportunity to see it in other places and just get that
yes,
perspective, whether it's like reinforcement or whether it's opening your mind to something else. I think both are really valuable.
yeah, and I had this conversation. I've had this conversation a couple of times recently, but talking about the very fundamentals of what we do in our profession in terms of the framework and philosophy, because I think a lot of the time we're always interested in like, I need to read more, I need to speak to this person, I need to have a look at this particular exercise, whatever it may be. But that fundamental thing of, well, how do I perceive the human body? What is my perspective on what I typically lean on clinically in using? Because we do have that issue of, if all you've got is a hammer, everything looks like
Yeah,
a nail, so to speak.
exactly. Yeah.
And it's actually one of the things in Australia, I think, too, where I love Australia. There's so many great things about living here, but geographically, we are so far away from everything else. And I think with that, we also miss out on certain ideas as well. And also because we are a small country in terms of population. But I'm probably digressing a little bit here, really. So, going back to your, you did your master's here in Australia and you end up doing your PhD. So I'm assuming you were someone who was interested to stay here long term.
Yeah, we actually went back for a few years to
Okay.
see, kind of feel it out. Actually, my husband's Australian, but he wanted to go to Canada and
Mm.
see what we thought about living there. And after a few years, I was pretty convinced I wanted to come back. So we came
Okay.
back. So we moved back in 2013. And then I work as a teaching and research academic at the University of Queensland. So like you said, I'm an associate professor now. And in my job here, I do research on like lower limb musculoskeletal injuries, from like the assessment to management and to the prevention aspects. So that's kind of
Mm.
my scope of research. And then I do teaching across the undergraduate, our graduate entry masters, and our like sports and musculoskeletal masters programs in lower limb. And I've taken on the role of program director for the Masters of Sports Physiotherapy and the Masters of Musculoskeletal Physiotherapy here.
Okay. So you do a lot of teaching specifically in those areas.
Yeah, yeah.
Was lower limb injuries always an area of interest, or was that sort of something that you got pushed into with your PhD and have run ever since with that? Or
No, I always an area of interest. So my PhD
yeah.
actually wasn't in it, and
Okay.
like I kind of took up the opportunity to learn more skills in a PhD rather than like
Mm.
necessarily the area I wanted to be in. But I've
Yes.
always liked lower limb injuries, and I think that probably comes from the fact that most of my injuries like have always been lower limb. I think you sometimes
Sure.
like how you get interested to learn more about them and stuff, but yeah, I've always been interested in the lower limb side of things.
So a lot of the research I've seen of yours is related to chronic ankle instability in particular. Is that your main area of main focus of lower limb injuries, or do you look at other areas of the leg as well?
Yeah, so I think probably my main research area is in I just call it the continuum of ankle injuries. So kind of
Okay.
the concept of an acute ankle injury to chronic ankle instability to ankle osteoarthritis.
Mhm.
So kind of looking at that, I guess, potential pathway that happens after ankle injury. So a lot of my work has been in that space. I've done some work in the knee space, looking at knee injuries and progression to osteoarthritis, and some in the injury prevention more generally space. But most of the goal is to prevent ankle and knee injury. So that's kind of where I've kept my focus.
That's a question actually I've asked, I've pondered myself, and I've asked other guests we've had on is why we see a lower prevalence of osteoarthritis in the ankle relative to the knee and the hip. Do you have any
Mhm.
particular thoughts or you know, give us some clarification of why do you see that particular phenomenon?
Yeah, I think that's a great question. And I think there's probably two ways to answer it potentially.
Mm,
One way to answer it is to look at is we don't have very good data on how
okay.
common ankle osteoarthritis is.
Okay.
So there are two studies that are referenced in that space. One of them isn't even really that specific to ankle osteoarthritis.
Mm,
And the other one is one like kind of there's this county project of the US that comes out of there. So I think we don't know necessarily how common ankle osteoarthritis is. So I don't know
mm,
that we have good data to make really good comparisons. The other, I think, thing that I think is relevant and interesting in ankle osteoarthritis is that, so if you talk about that whole, like my idea of that continuum I mentioned before, where like ankle osteoarthritis, one of the interesting things about it is they estimate that over 80% of it, like some people say 86%, but over 80% of it is post-traumatic, which means that it happens as a consequence of some injury that
mm.
happened previously. And that might be like an ankle fracture, could be ankle sprains, could be repeat sprains, having chronic ankle instability. So there's some incidents that predispose the person to having ankle osteoarthritis. So, and I think that idea of that continuum is interesting in that after fractures and after ankle sprains, um, having ankle pain is actually more common than we initially realized. So
Mm.
there's a systematic review that was published a few years ago. I don't actually know if it's published now or if it's from a conference. I can't remember if it's published or not, but they basically looked at the prevalence of pain in people who have chronic ankle instability. And depending on the study that reported it, it was from about one quarter to about three quarters of people had pain. And some of them, and there is other studies that have shown that, oh, well, in people with ankle instability, you see cartilage defects, you see these other things.
Mm-hmm.
So part of my mind thinks, well, is that actually just the start of arthritis? And we don't call it that yet because we have
Mm.
another name for it. So I think with it's becoming increasingly, I guess, more talked about, because if you look at the chronic ankle instability, the way it's really defined on things like repeated ankle sprains, on feelings of instability, feelings of
Mm.
giving away. But pain doesn't really come into that definition. And so in the last, like maybe 5 years, there's a lot more talk, a lot more discussion about pain in chronic ankle instability. And I guess that's where I think about, well, are we not counting all those people that have, like, do they actually have the starting point or osteoarthritis? We just don't actually count them in our numbers. So I
Mm.
feel like I don't understand the full prevalence of ankylosing arthritis, if that makes sense.
Well, that was actually going to be a follow-up question I had is how do you define chronic ankle instability
Yeah.
itself? Because, well, yeah, what are its characteristics? Because I think a lot of the time people think of it as, oh, well, you have recurrent ankle sprains
Yeah.
because you quote unquote don't have good active stabilization or stiffness.
Yeah.
Is that simply it, or is it pretty poorly defined and actually includes a lot of different types of potential symptoms?
Well, so about, I think it was about 2016 now. The International Ankle Consortium is basically an international organization or group that their mission or their goal is to further research into ankle injuries, to increase dissemination, to better understand treatment management of ankle injuries. And so I'm actually chair of that organization at the moment.
Okay.
But before I was chair, back in 2016, they published a paper that was like kind of an agreement on how we should define chronic ankle instability and a bit about terminology. Because if you look at old research, you see things like chronic ankle instability, you see perceived ankle instability, mechanical ankle instability, and all these different words that people were using a little bit interchangeably and that weren't really well clarified or defined. And there was some
Mm.
confusion on if they're the same thing, if they're different things. So the International Ankle Consortium brought together like what I guess what they consider like a group of experts for consensus, and their consensus was that the term should be chronic ankle instability rather than mechanical or perceived, being those things maybe weren't relevant to differentiate. And they kind of came up with a bit of a, I guess they call them selection criteria. So it's kind of for research, I guess, in that purpose to make sure that research studies are using a consistent demographic or consistent patient population, but also works clinically. So they basically indicate that it should be someone who's had obviously a previous ankle sprain. They haven't had an acute sprain in the last 3 months, trying to differentiate it from symptoms of an acute injury. And then the individual should basically experience one of three symptoms, and that's feelings of instability, which they usually we define like on a questionnaire or a scale. Episodes of giving away, so at least 2 episodes of giving away that happens like in the last few months, and then the last element is repeated sprain. So it's kind of a broad definition that if you haven't sprained but always give away, but don't end up with an acute swollen ankle, that still can be considered chronic ankle instability, or it can be in someone who regularly sprains their ankle. So that's kind of the way they defined chronic ankle instability.
Probably a simple question, but with probably a complex answer. What causes chronic ankle instability?
Yeah, great question. And definitely not a simple answer for sure.
Mm.
To be honest, like the pure answers, I don't think we fully understand
Mm.
why some people get chronic ankle instability and other people don't. So there's the concept similar to like the ACL literature, the way they talk about like copers and non-copers you hear in the
Yes.
ACL world. They use a similar concept in ankles where they'll talk about like you can have an acute ankle injury, you can become a coper, which means you don't sprain again and you
Mm.
kind of have a ankle that isn't associated with injury, or you can develop chronic ankle instability. And there's been lots of speculation, I guess, in trying to work out why people develop why some people become copers and some people develop chronic ankle instability.
Mm.
Um, I don't think we know. I don't think we can clearly and definitively say this is the reasons why some people get it and some people don't. Um, there's been lots of things looking at things like, well, is it biomechanics that persist after an acute injury, for example, and those biomechanics may then, change movement patterns, etc., and lead to,
Mhm.
repeated sprains or feelings of instability. There's things like, I guess people's so one thing that that I think is really interesting is the concept of like people's perceived confidence in their ankles, how
Mm.
that maybe changes how people do things, how people approach things, their hesitancy, etc. Some people suggest that it's a proprioceptive deficit. So if you don't resolve your proprioceptive or balance impairments, then you have an increased risk of getting chronic ankle instability. Some people talk about muscle strength being a factor, but that gets a bit gray because there actually isn't any data saying that we have decreased strength after an acute
Well,
sprain. So
I was
that's
going to ask on this. Yeah, as you propose some of these factors, are these just proposed risk factors, or is there actually some good evidence to support that these things are relevant to
so
developing?
there's evidence to say that if you compare a group of people who have chronic ankle instability and those who don't, you'll find deficits in those things. So you'll find that they have people with chronic ankle instability generally have decreased balance, decreased proprioception, etc., compared to people who don't have the injury. But from that doesn't mean it's a prospective risk factor, right? It means it's
Yes,
the difference
yes.
between. So we
Correlation versus causation here.
exactly.
Yes.
So we
Yeah.
know it's present, but we don't know that it caused it. So I
Mm.
think that's where some of the things come up. Some of the, like, probably some of the best evidence suggests that body weight
Mm.
might play a role. That there's some studies to suggest that like higher body weight or higher BMI, that you have an increased risk of developing chronic ankle instability. But a lot of the other, I guess, more, physiological type pathophysiological factors, I think a lot of them are quite speculative, are based
Mm.
off case control studies, not longitudinal studies.
Is there any indications about seeing certain structural damage as a
Yeah.
predisposing factor, I should say, to developing chronic ankle instability? And like I'm thinking specifically, like thinking about ligamentous structures. But the other one I actually think about, and I'm interested to hear your thoughts on this, uh, with some of the stuff I'm learning from this course in Italy, they talk a lot about the retinaculum.
Yeah.
When you think about the ankle, there are very well defined retinaculum around the ankle, the
Yeah.
superior and inferior extensor retinaculum, perineal flexor retinaculum. And I know traditionally a lot of people thought of the retinaculum as simply thickenings of connective tissue to hold tendons in place, but there seems to be they seem to be very highly innovated in particular in proprioceptors. And there's been some discussion, I know, and some research done, relatively small scale research, of looking at structural damage to these tissue that can affect also feedback from the periphery. Are these things that are they relevant, or do we know much about their role, and whether it's the retinaculum, ligamentous structures, or other tissue structures around the ankle itself?
Yeah. I don't think we know enough about their roles. I think,
Mm.
I guess probably I know very little. Like, I don't think there's basically any research that I'm aware of looking at the retinaculum and their involvement after an ankle injury. I think with the ligament side of it, it's interesting. Most people, well, and maybe there's a threshold, like, and I'll explain that in a second, where it's lots of times it's generally thought that the amount of laxity doesn't necessarily correspond to function. So some people who you test and they feel like they're really lax, they're functionally fine.
Yes.
Like people, you test them and then they don't feel lax at all, they're functionally worse. So it seems like you can't, like, it's hard to predict that, oh, this person's really lax, they're going to have worse function or worse outcomes. Doesn't seem to necessarily equate. Whether there's a threshold there, I don't know. So whether there's a point where if you're beyond this one certain point, then maybe you are functionally going to be worse or maybe not. So I
Mm.
don't think we understand, like, I don't like generally it sounds like there's not a relationship between ligament laxity necessarily and function. However, there might be a point where if you're beyond a certain point, then that will functionally change you. I think
Yeah, go
sorry,
on.
one of the interesting
Go on. Yeah.
like other elements of the ankle sprain is looking at like cartilaginous lesions and things like
Yes.
that as well. And so like your typical, if someone sprained their ankle, the typical go-to is you apply your auto ankle rules, you decide if they
Mm.
need to go for an x-ray, and you
Mm.
x-ray them.
Mhm.
And that will tell you if there's a fracture or not. And then generally that's like obviously going to direct your management. But MRIs is a lot less common. So your x-ray is usually your go-to to rule out fracture, and then they're going to be managed as a sprain. So
Mhm.
I don't necessarily know that we have a good, I don't know, I guess, idea of how many people who sprain their ankle have like cartilage damage, particularly around the talar
Mm.
dome, for example, things
Mm.
like that. And there are definitely studies that have looked at bone marrow lesions in people with chronic ankle instability. And so in people with chronic ankle instability, I think there's something like I don't know, like just less than half of people were found to have cartilage injuries in this population they looked at in this study. And maybe like a third or something had bone marrow edema. And then synovitis was even more common. So, the irritation of the joint itself was even more common. I can't remember the exact percentage, but maybe like 3/4, something like that. And so with all of those things present in chronic ankle instability, like it kind of makes my mind wonder, well, how many of those are like recurring things that happen that maybe happen from the acute injury? And then you can think of, well, whenever if your ankle gets irritated, gets annoyed, gets a bit inflamed, that has other, I guess, implications to things like your muscles, your, peripheral receptors, your proprioception, etc. So whether that's almost like a loop that keeps happening, like that's purely my speculation. So like there's evidence to say that these things are present, but how they influence things, we don't know.
See, I'm glad you said that, because I've also found clinically, excuse me, that so often you'll see. I'll grab some water, hang on, before I keep
I might do
coughing.
it at the same time.
Excuse me, try that again. How often you will see a ankle sprain, and they may present with what you consider to be a mild to moderate ankle inversion injury, yet excuse me, I think I'm better now.
That's right. It's
Yet actually have ongoing symptoms for sometimes several months. And actually a lot of the symptoms that they present with seem to be more related to intra-articular pain, swelling. And it may not necessarily be a cartilaginous lesion, like obviously you can have, that can occur. But the simple fact of just bony bruising within the joint space itself. And I think that you see that a lot, because the reality is some ankle injuries, you might apply a very high amount of compressive force that causes some strain and damage to ligamentous tissue, but a lot of bruising and bone marrow edema that actually may take several months to actually completely settle down. You can even see that sometimes too with looking at clinical assessment. The lateral ankle complex looks good, but they actually have a little bit of a joint effusion you see around the ankle joint itself.
Yeah, no, I think that's really accurate as well, and the fusion might come and go, right, depending on their load, because and that's one thing I think that, I don't know, gets confusing sometimes with ankle injuries, is that it's looked upon as a pretty minor injury, right? So lots of like only an ankle sprain, it'll be totally fine. And then so people that potentially have deficits, first of all, so like there's lots of data that shows that most people with an ankle injury, they go to, depending on the data, some people go back, like in US athletic system, I think the average was something like 3 to 7 days.
Yes.
And that almost 100% of them went back with some kind of deficits.
Yes.
And so some of those deficits are things like your balance or like your proprioceptive elements, things like that. But some deficits too are more like your your like that's pathological, with you have swelling, etc. So whether that then leads into that cycle, we also know that like if you have a second ankle sprain, which are obviously super common to have a recurrent injury, the most common time for that is in the first 6 months. So maybe that's when none of this stuff is quite, like it can take 3 months for some of your bone like lesions and stuff to heal. So maybe we're looking at those things as being contributing factors there. Again, that's purely speculation because we don't have any data to say that's the case. But I guess you kind of wonder about, us not fully understanding the potential changes that happen, particularly intra-articularly after an ankle injury.
Yeah, and I think like you said, I think there's a common belief or perception that most ankle sprains are 2 to 3 weeks. You don't really think much of it. And I think even within the general public, people are much less concerned with an ankle sprain than, let's say, when you pivot on your leg and you feel a pop in your knee. And I think people typically have a bit more concern and raise an eyebrow. You mentioned before about contributing factors with biomechanics as well.
Yeah.
Is there any evidence to suggest that there are biomechanical deficits that you see that contribute to ankle instability? And I'm thinking also too throughout the whole kinetic chain, because I know there's a very interesting study I remember reading. I think it was published in 2007 by a guy with the surname English. I think he's actually an Aussie guy, of looking at EMG changes around the hip following an ankle sprain. And so, it really highlights some of the important feedback that we get from the ankle through the kinetic chain.
Yeah.
So, do we, and probably can extend that to think of, is there any changes in biomechanics or risk factors for biomechanics and also tissue capacity or strength, not just around the ankle, but also further up in the kinetic chain?
Yeah, and I think that I guess understanding in that space has definitely grown in the last few years. And one of our PhD students here did a study looking at proximal muscle strength in
Mm,
people with chronic ankle instability and in people after an acute sprain. And that study's been done in the US as well. So there's a couple of iterations of that. But what we found with strength from a strength perspective is that there were deficits in at hip and knee strength. So we found things like hip abduction, hip flexion extension, knee flexion extension, strength deficits in people who've had chronic ankle instability compared to controls.
mm,
And that was replicated in the US very similarly as well. So it does seem like there's, I guess, proximal effects of that distal injury. Um, and how that relates to chronic ankle instability, I think, is fairly interesting in that, like I mentioned, this PhD student also looked at strength deficits after an acute ankle injury. So we looked at hip and knee as well. And when we compared hip and knee strength to like people who had sprained their ankle but were now pain free, so we didn't have any pain inhibition, no pain issues like that. And we compared them to controls. There was no difference in their strength. So they had no deficits in hip and knee strength after an acute injury. And then we followed them up after 6 weeks just to see if it was like time from being potentially away from sport for a little bit that maybe
mm,
caused them to have a few deficits. And they were the same as they didn't change. So there was no
mm.
deficits from them compared to acute to 6 weeks or compared to controls.
Okay.
So I thought that was interesting because what that kind of suggested to us is that we see these proximal changes in chronic ankle instability that maybe aren't there from the beginning, that develop along the pathway somewhere. But where they develop, I don't know. So
Mm,
when does that, like, is it the, like, maybe because obviously we looked at comparing two groups, right? So maybe it was some of our group had a small change, some of our group didn't have a change, and we don't see that. We didn't subdivide them to who got chronic ankle instability, for example. So is there a proportion of people who develop impairments in strength proximally, or is that something that happens with repeated injury and repeated sprain or feelings of instability? So I don't think we know
mm,
where that happens from a cause effect or along that continuum. But I guess the other part of that too, so I guess evidence of proximal strength deficits in chronic ankle instability. Um, there's been a lot of studies looking at mechanics or proximal mechanics to see, and I guess that's interesting to see, well, if you have deficits in strength proximally, do you have changes in mechanics proximally? And I think the literature is all over the place with
mm,
mechanics. So,
mm,
like, we've done some studies looking at mechanics and we've shown that there are small changes in mechanics. We've actually tried to do this is not published or anything, but we tried to do a systematic review to kind of collate information because there's so many different studies that look at things
mm.
out there. We tried to bring it together to see, like, are there differences? Are
Okay.
there not? And like, so first of all, the research is pretty hard to bring together and interpret because different tasks are performed. People look at like joint positions, for example, for mechanics in different positions, maybe like 40 milliseconds before initial contact, at initial contact, this much many milliseconds after initial contact. So all those are different. So you can't bring those together. So bringing information together to understand mechanical deficits was quite challenging. In the few things that we could bring together, so we could bring a couple things together, like about a vertical jump, but we actually found very few differences.
Mm,
So no differences in, I think the only difference we found was some ankle frontal plane kinematics, but no differences like in the other areas. But again, we couldn't bring together lots of information because it was pretty limited in what was able to be pooled. So I think the short
yeah.
answer is I don't think we quite understand what kinematic deficits are present and what they
Mm,
mean and if they're clinically meaningful. Because, like, so our study that looked at kinematics, I think our degrees were between about 3 and 4 degrees of difference. Like, for example,
mm,
for hip motion, 3 or 4 degrees difference between
mm.
a chronic ankle instability group and a control group. And is that a meaningful amount of difference or not? So I think I'm like, I haven't made any decisions in my head to how mechanics fits in because I don't think I fully understand it well enough yet.
Where does that leave us then? Because I'm just thinking about then clinically, how do we approach dealing with someone with chronic ankle instability? Because there seems to be a lot of inconsistencies or unknowns within the literature.
Yeah.
So, are there any recommendations that you give or any kind of framework that you would recommend to clinicians when they come across someone with chronic ankle instability?
Yeah, I guess I like clinicians probably have their go-tos, right? Like the things that
Sure.
they probably go to. So like obviously of course like your your politically correct answer is you're going to look at the patient and see where the episodes are, etc. But
Yeah, yeah.
I think go-tos for me is I'll always look at like their balance, proprioception, kind of awareness of their position in space. That will be a go-to for me. That I'll always
Mm,
have a look at that. Um, I'll always have a look at their movement just to get an idea of what I see with movement, and that might lead on to some strength testing and stuff as well.
mm,
Um, but I do typically look at some of their hip and knee strength. And I think one of the reasons I look at that too is, I guess, if you think about the ankle sprain, so lots of it's to do with landing, change of direction, that kind of thing. And you need some element of shock absorption for those tasks, right? So if you think about your posterior kinetic chain, obviously your ankle, your calf, like all like quads are important, glutes are important, etc. So I kind of guess one of the things I look at is look at their posterior kinetic chain to make sure that I think they're absorbing things well. Because I guess I want to make sure if they're landing hard, if they're not controlling their descent, etc., that might put them at risk. But again, just based on we know there's some deficits in some of those muscle groups, I will look at those. From a balance perspective, one thing, so I probably have changed this a little bit, is that the star excursion balance test is kind of often a go-to balance test, or
mm.
like I would use a Y balance test, so not 8 directions, but 3 directions for Y balance. Like I guess that's kind of a common go-to test, but one of the things that we showed in our studies, actually been replicated as well, is that hip strength affects your distance reached in your
Mm.
star excursion balance test or your Y balance test, in your particularly in your posterior directions. And we know that ankle dorsiflexion range of motion affects
Yeah.
your distance reached in your anterior direction. And we know that both of those things, the dorsiflexion range and hip strength, are both problematic in chronic ankle instability.
Mm.
So sometimes I look at my star excursion test and I think, is it a balance deficit? Is it dorsiflexion range of motion deficit? Or is it a hip strength deficit? So I've actually
I-
kind of always make sure I do other balance
Yeah.
assessment to really understand what's contributing to what.
I'm glad you said that because I often think sometimes people look at balance a little bit too simplistically. And there's a two elements of one is their ability not to do the task because they actually have tissue capacity deficits, range of movement, strength are obviously key
Yeah.
ones. But the other one, and this is a question for you too, is looking at the difference between static versus
Mhm.
dynamic balance. Because I think about star excursion, Y balance tests, they're very slow velocity type balance tasks.
Yeah.
And I mean, I see it all the time clinically where, and it's not to say that you shouldn't consider doing what the results of those tests you find and that you shouldn't address those deficits. But the reality is most people do an ankle injury with high velocity movement. So
Mhm.
shouldn't we be
Yeah.
looking at high velocity tasks and their ability to maintain effective balance um, strategies during those tasks?
Yeah. Yeah. And I think that I don't know if it's the hardest part, the biggest barrier is ease of testing,
Mm,
in that testing high velocity tests or movements and tasks is harder to do than testing like a single leg stance times or a
mm.
Y balance test, for example. So I think sometimes we default to what's easier and feasible to measure. I do think though that like there's a million different hop tests out there. I'm in shock to how many different hop tests we've come up
Yeah,
with on how
yeah.
to assess balance. So there are definitely different tests like that from a perturbation or from I guess, a dynamic challenge perspective. But I guess one of the things that I use a lot that I actually rate, so I think I've increased my rating of this as well, or my weighting of this clinically, is how someone feels. So
Mm,
in terms of their perception of their like, so different people call it different things, but like people's perceived instability, so how stable they feel their ankle is, how confident they feel doing the task, which people often call confidence, and then how confident they won't sprain their ankle doing the task. So some people call that reassurance. So there's different terminology people use. But when I do my balance tests, I get those insights from the patient as well. And some tests, like, for example, like when, like, it's easy to train balance. For example, you might be doing like landing perturbation. So, using your rugby ball, like, your full mat, and you're perturbing them when they're balancing. And it's hard to get an objective measure of that, because you can measure like their balance in an area, perhaps that probably dependent on how hard you push them, etc. So it's hard
yes.
to get a quantifiable measure. But what I think is really useful with those tests is I'll ask them, how confident did you feel in your ankle when we did that?
Mm.
And I'll get them to rate their confidence for me, just on like a numerical rating scale. And that I think is really helpful for me to see how they feel doing the task, in terms of their perception of their balance and their stability and confidence.
The other question I wanted to ask with assessing tissue capacity is active stiffness. And this actually ties in with looking at a few different capacities. It looks at, I think of something like a depth jump, from a box, jumping down,
Yeah.
jumping up in the air. And the good thing is actually we have technology, you can use your smartphone now and certain apps to actually measure this.
Mm.
And I'm interested to, is there actually any research of looking at active stiffness, i.e., how quickly you can get off the ground from doing a depth jump task related to uh, the susceptibility to ankle injury or chronic ankle instability? And can that actually fit in also too as a dynamic balance task too? Because you're obviously having to, particularly if you're doing it on a single leg and you're changing direction, it does really require a lot of elements required from most team sports or most sports that people are performing when they do injure their ankle.
Yeah, yeah. I don't know of any data that links, like basically looking at like how fast you go off the ground, right? Like your
Yeah.
reactivity of that task. So I don't know of any data that links that with ankle injuries.
Mm,
I think you're right. We have growing capacity to measure these things now, right? Because there seems to be a lot more clinically based equipment that can measure things like your reaction time, like your rate of force development, etc. So I think our capacity is growing to evaluate these things. I think understanding what they mean is another thing, though, is that we can
mm.
now measure more things, but we understand what that tells us. So I think it's understanding both elements of those too.
Yeah, for sure. And look, I mean, the way I typically will approach such a problem too is you're doing a gamut of tests to get an indication of different kinds of capacities from flexibility to strength to rate of force
Yeah,
development. Because I think that's when you start to get an opportunity, at least from a clinical perspective, of going, well, actually, is there inability to do a depth jumps task because they actually even lack range of movement? It could be
exactly.
something
Can they
simple
not
as
absorb
that.
their force? Do they like
For
dorsiflexion range,
sure.
something like that? Yeah, so
Yeah,
many
yeah.
things. Calf tightness. Yeah.
Are there any indications for surgery in chronic ankle instability? Now, I imagine there's probably, again, a complex question to answer, but I'm interested to hear if there are any indications for it.
Yeah, I think I think one of the complicated things with I get yeah, one of the complicated things to make the decision like when is surgery needed or isn't needed is we don't have good research comparing surgical and non-surgical treatment. So like in the ideal world, we would have research which has taken a group of people, 50% went to non-surgical, 50% went to surgical, and then we see what happened in 6 months and whatever that would be. But we don't have those studies. So most surgical studies look at other cohort studies, so following them over time to see if they're better before or after compared to before. Lots of them compare different surgical interventions. So there aren't, to my understanding, there's not any good research that compares surgery versus non-surgery. So that's kind of a deficit in our understanding.
Mhm.
One of the things so there's a systematic review. It's actually getting quite old now, but it was a systematic review of systematic reviews. So basically looked at the highest quality evidence and then reviewed that and then meta-analyzed it to try to bring things together. And one of their conclusions at that point as well is that we don't have enough information. So no studies had compared surgical versus non-surgical. And one of the things that was interesting, well, in all of the surgical studies too, is that most of them talk about how surgical intervention was implemented after non-surgical management had failed. But
Hmm.
most of the time, we have no idea what failed.
Yeah.
So that's one thing I think is a big limitation as well, is that there'll be reports that, oh, that surgery is needed when they don't. So kind of the general premise, I guess, is that people would go to surgery when they haven't responded favorably to non-surgical management. But I think that we need to be careful that that's good non-surgical management because we know that people are treated in lots of different ways. And what
Mm,
someone says that, they may have said I had non-surgical management, but it maybe wasn't what was appropriate or best evidence based. So I think that I think we need a better understanding of how many people fail after appropriate non-surgical management to understand when surgery is needed.
mm,
Um, and like, I think it's interesting too that the uncertainty around the relationship between ligament laxity and symptoms. So, because
mm.
that's what surgery is doing, right? It's anatomically making you more stable usually from a ligament laxity perspective, but potentially if there's cartilage, like if there's issues with cartilage, it might be like cleaning that area out and that's different as well. But I don't think we know enough about the relationship between laxity and function to know if
Mm.
fixing laxity fixes function.
Going back to talking about ankle osteoarthritis, and one of the things that you mentioned early on was typically osteoarthritis of the ankle will develop following some type of acute trauma.
Yeah.
And this is obviously very common in any joint, whether it's knee, hip, wherever it may be. The thing that's different though, and this is something that I've considered a lot, is we obviously develop a lot of osteoarthritis of the knee and the hip in individuals who've never had prior trauma to that injury. And a lot of this obviously ties in with the fact that OA is very much a systemic
Yeah.
problem, and that there are non-musculoskeletal factors that contribute to the development of OA. So this doesn't seem to be as relevant to the ankle. Is there any hypothesis for why this is the case?
Yeah, that's a great question. So yeah, so primary OA at the ankle is much less common than it is in other joints for sure. So the secondary or post-traumatic OA is more common, whereas the primary considerably less common. Interestingly, when we've done some research on ankle OA, we do find that people with ankle OA do have a higher BMI. So they do have,
Okay.
like being one of those systemic factors that can increase inflammation in a joint, of course. So, and
Mm,
obviously BMI has multiple factors, right? There's the loading aspect on the joint as well as the inflammatory and the systemic
yes.
changes. So
Yes.
it seems like that is like ankle OA does like have this typical, like a stereotype in terms of, body type for OA being that people are commonly have increased body mass,
Mm,
but it doesn't seem to necessarily, I guess, be from the primary aspect of that. And I think there's a couple things with that. So first of all, obviously, if you have an injury and you have osteoarthritis, you may be less active because of pain, because of etc. So perhaps it's a secondary, element to having the OA.
sure.
But in terms of the predictor role, I guess one of the things I think is interesting is that the whole, like some of the strongest evidence for chronic ankle instability is having a higher BMI. So
Mm,
whether that's like one element of that, again, that pathway. So perhaps BMI, whether that's almost like a adjunct or like a facilitator, or you know what I mean, like a accelerator, whatever you want to call it, like into that continuum. I don't know.
well, it's actually funny, and
So,
this is just me completely speculating off the top of my head based on not being a neuroscientist or anything like that. But I actually think about too of when you think about elevated BMI or a high amount of adipose tissue, that can cause systemic dysfunction. But I also think about its impact on potentially like our psycho-emotional state because of
yeah.
neuroinflammation. And you talk about the relationship with confidence in your
Mhm.
ankle and susceptibility to ankle instability. And again, I'm basing this off of someone who's not an expert in this field, but just from a first principle standpoint, you do wonder if there's some relationship there too.
Yeah, yeah. One of
Yeah.
the things that's interesting about ankle OA as well is so most people with ankle OA were quite active because
Mm,
like ankle sprains and ankle fractures are obviously your most common injury in most sports, right? So a
yes.
lot of people, that's how they injured themselves. So
Yes.
it was through an active lifestyle. So one of the things that we find in ankle OA is that people have a lot of, I guess, psychosocial, emotional, like contributors or like accompanying factors with ankle OA. And a number of those stem from the fact that their lifestyle has changed so much because of their injury. So
Mm,
I guess there's one element if you have primary OA as an example and you weren't really ever active and developed OA as a primary, then you never missed not being active. So it wasn't something
mm,
that you had to lose in that
mm,
journey for OA. But one thing that's really come out, we've done a number of like, I guess, qualitative studies trying to better understand people's experiences with ankle OA. And it's amazing how many people have talked about like the lower enjoyment in their life
mm,
because they can't do what they like in their life. And almost all of that is being active.
mm.
So I think that's something that's a little bit, maybe more, potentially a bit more unique to the population because of the history of injury and how that injury often occurred.
Yeah, no, that's a really good point. Just thinking back to chronic ankle instability for a moment, I've asked a lot of questions. We've talked a lot about thinking up the kinetic chain, but what about actually down at the foot? And
Mm,
thinking about the mid and forefoot in particular. Is there actually any evidence looking at deficits in that area? And like one thing I think of straight away is say big toe extension as a common one that I'll typically look at least, and its
yeah.
relationship to ankle injuries or chronic ankle instability.
Yeah, so I there's been more research about more somatosensory changes at the
Mm.
foot necessarily, rather than, I guess, like, muscular tendon factors that way.
Yes. Okay. Yes.
I actually had a really interesting conversation with someone the other day about this, though. And our discussion was about, I guess, limitations to dorsiflexion range of motion,
Mm.
and how your, like, for example, like tightness of things, tightness of your long tendons can contribute to that as well. So they're talking a lot about needing to, like, the potential need to evaluate the effects of long tendons on dorsiflexion range by looking at, like, for example, like a hallux and extension,
Yes.
going to dorsiflexion range of motion to see if that's a limiting factor. And so I think there's probably, I guess, more growing consideration of
Mm.
the other muscles in the foot, and even like things about your intrinsic foot muscles, like they're obviously important for foot posture, for some of your absorption of load from your, like, generation of force, etc., from that stability of the foot component. So I don't think we necessarily understand their roles necessarily in ankle sprains or ankle instability either, and to whether they
Mm.
have, whether they contribute to anything as well.
The other area of research or a paper that I came across of yours that I was particularly fascinated about was looking at the predictability of match performance in soccer players. And what you found from that paper, which highlighted skill, was a predominant factor for
Mm,
performance. Um, and also it also highlighted that skill predicted movement, not athletic ability.
yeah.
And that's a very interesting area to explore, because I think, particularly for a lot of physiotherapists who work in high performance or in sport, you're thinking about building up tissue capacity, strength,
Yeah.
power, rate of force development, because you think that that's going to improve their ability to move effectively. But this was suggesting, well, no, it's really more reflective of this skill component. So I'm
Yeah.
actually interested for you to elaborate a little bit more on the findings of this study. And I'm also interested to understand how you quantified skill itself.
Yeah. Okay. Yeah. Um, yeah. It was interesting to me in a whole bunch of reasons, and to me there are a whole bunch of take homes. So I guess for context, first of all, is written in an evolutionary
Mm,
biological context. So
yes.
lots of people in the sports world would not have come across this paper, or
Mm,
have, like, thought about its application to sport, because I collaborated with a biologist, an evolutionary biologist, on this study. So it is a different take on things. But I think there's some really, really cool take homes from the, like, sports rehab and sport performance and development takes. But I guess to talk about the study first, and then maybe the take homes in a second.
sure.
So in terms of skill, well, so we looked at, I guess we had 5 different components of assessment. So we looked at, like, morphometry, which looked at, like, your height, your weight, your limb length, etc. We looked at balance, and we used this, like, balanced eyes closed on foam, trying to make it easy to do. We did it all in the soccer field, so it had to be all able to do, like, in the environment. And then athleticism, we looked at things like sprint speed, endurance, power, things like that. And then skill, we looked at more, like, accuracy of passing. So example, like, we had targets. So we had targets that were almost like, you know, like a pseudo dartboard, but more spread out, I guess, in that they had to hit targets, so different points for hitting targets. So we did that for passing accuracy, like volleying accuracy, so ball off the ground, heading accuracy, and we did shooting capacity with that as well. And then we looked at things like dribbling speed and juggling ability, so kind of more ball skills. So that's kind of the idea of, like, trying to break down the different skills that are happening in a soccer game, to understand the skill component. And then we looked at soccer performance in 2 ways. So we had a PhD student working with us, where she was amazing, where we videoed soccer matches, like the typical outdoor 11 on 11 soccer matches. And then she analyzed every player in all
Mm,
the matches that were videoed. So it would be like, looked at things like dribbling, challenging, another passing, shooting, interception, and looked at success or not success for all the different tasks with criteria. So it was a huge exercise to
mm,
analyze all of the data there. And that was kind of like that match performance. So what it meant. And then we did another element of that, which was like soccer tennis. So kind of like you individually having 3 touches to get the ball to the other court, which is a common, like, soccer activity. So we kind of use that as a match, like, assessment of match performance. But what we found interestingly was like you said, soccer skill was the best predictor of performance, and then balance also related to performance as well. I think those things are really cool in
Mm,
that, first of all, I guess one thing I thought was cool from a non-physio perspective is that there's so much talk about like having the right morphometry for sport. And I'm like, I love that your morphometry didn't come into it. So, it
mm,
didn't matter if you're tall, it didn't matter if you're short, it didn't matter if you had long arms, etc. So I liked that because it didn't pinch in people, I guess, in my head. So it was kind of a cool thing that way. I also thought it was really cool that balance came out as a relationship with performance. And I think that's really interesting because we sell balance as being really important from a rehab perspective, from an injury prevention perspective. But I like that it showed that it actually also links to performance,
mm,
and that your skill will be better if you have better balance. Like I was basically one of the take homes for that. So I think
mm.
from us trying to sell why balance things may be important to do from prevention programs, etc., then I think that can help with us. It's like, this is actually for your skill enhancement, for your performance enhancement, rather than selling it as, oh, if you do this, you won't get injured as much. Like, people don't
Yes.
seem to grab onto that as much, right? They seem to grab onto say,
No.
this will make you a better soccer player.
Well, it doesn't surprise me though that balance also was correlated because I
No,
think
me
of
neither.
no, because I think of balance too. Balance is an end product of multiple systems in play. Because like
Definitely.
we mentioned before, when you think about, well, is the actual deficiency maybe a tissue capacity, or like, and I think about the sensory proprioceptive feedback. It's ultimately how effective is your sensory motor system
Yep.
at being able to maintain base of your center of gravity over your base of support due
Yeah.
to internal external perturbations.
Yeah.
But
Which sport is full of.
yeah, and it's an interesting area because I think this is something that we don't consider enough. Is this overall idea of coordination or motor
Yeah.
capacity? And like my colleague John, who I often do the podcast with, we often talk about this idea of like the hardware software problem, because you have people who have amazing software, like their ability to be able to do very complex tasks and problem solve physical motor tasks is amazing.
Mm.
And maybe they need to work on the hardware, actually
Yeah.
building up some tissue capacity. But just that pure focus on tissue capacity often can not lead you to getting the best outcomes. And even clinically,
Yeah.
like even in non-athletic populations, it amazes me when you go through with someone who, let's say, presents with ankle instability or patellofemoral pain. You look at their tissue capacity, look at their biomechanics. You may not necessarily see a deficiency, but then you ask them, for instance, to do a series of running tasks. All right,
Mm.
can you have a go at doing a skip, a grapevine, an A skip? And you look at them and you go, oh my God, you're really struggling to do that. And it's
Yeah.
often a big deficit. And it's reflective of, okay, maybe that person actually needs to work on the ability to problem solve motor tasks. It's
Yeah.
not necessarily related to their tissue capacity. But
Yeah.
it's
Yeah.
interesting to think about then how we can quantify that, because I mean, perhaps we can think about sport specific things for sure, but then I think about how we can be a bit more objective of doing that, particularly in a clinical real world setting as well.
Yeah. And I think too that like the concept of the soccer specific skills predicting match performance rather than the athletic stuff, I think that's a
Mm,
really good take home for us as physios as well. And that, like, lots of times we think about like, oh, I have to get them back, like I have to get their speed back, I have to get their power back, I have to get their
yes.
change of direction ability back. And all of those things were in the athletic component that didn't predict match performance. So while they're obviously going to be a base for things, then I think the really big highlight too is that to get them back to performance, though, that's where you need the specific activities from the sport. So
Yes.
like making sure, and I know I hear all the time that physios kind of get, not accused is not word, but get told that they're not going far enough, that you're stopping your rehab too early, we're not getting people
Yeah.
back to the level. And I think really making sure that, like, I think the study showed us as well, that you have to progress beyond those physiological or physical measures and progress
Mm,
into skill measures as well. And lots of times that's of course working with coaches, working with teams, etc. But I also like that because, I guess it aligned with other ways that we think in that. So one thing that we published a couple of years ago was the past framework on return to sport after an acute ankle injury. And one of the things that came out, so that was basically a consensus paper, a consensus opinion on what the, I guess, things were that needed to be assessed to determine an athlete's ability to return to sport. And in that framework, sport specific activities and sport specific skill was really strongly like it was like it reached consensus really easily. It was thought to be
Yeah.
a really essential contributor to return to sport. I think that this study aligns with that really well. That's saying, well, that's your end, that's your getting back to performance, right? So you may be getting back to sport safely, but to get back to performance, you need to, extend to that skill specific level. So I think that aligns really
Mm.
well with our return to sport continuum.
Yeah, and look, I think you hit it on the nail on the head in that you have to be careful not to get too obsessed with rehab only being in a gym or rehab
Definitely.
setting. And the other way I look at it too is when we do testing, particularly in a closed environment, these are all just proxies. Ultimately, the best measure we can do is look at someone within the context of where they need to perform, doing the tasks that they need to do. And, it's a very simple thing, but most of the time to return to actual play in particular, you've got to have a certain amount of volume doing training and as close to performance or competition as possible, because that is the ultimate conditioning that you can do.
Yeah. Yeah, so that's like progressing your physio, right? From your clinic
Absolutely.
from your gym to the field, court, whatever that might be for the athlete. Yeah.
Well, and I think that's why too, and not to say that if you're a physio working in a sport that you're not familiar with that sport that you can't excel, but the reality is I think so many physios who work in a particular sport that they used to perform in, particularly at a relatively high level, do have an advantage because they
Mm.
understand the physical tasks and requirements, and they can actually integrate a lot of the sport specific training elements into the rehabilitation process.
Yeah. Yeah.
And you know the right questions to ask to make sure that they actually are achieving the things that they need to, because you can have all the right skills in assessing all the individual biomotor abilities, but if you're not looking at the bigger picture of, well, can this person run, kick a ball, change a direction, and what happens also over time with fatigue, you're probably missing the bigger picture.
Yeah. No, I
Yeah.
definitely agree with you.
Yeah.
Yeah. Yeah.
A question I always like to ask our guests is things that you're interested in doing outside of your clinical or research work. Are there any particular hobbies or interests that you like to explore or pursue?
Um, I think probably, I guess if I get to choose my weekend for downtime kind of thing, so I actually just called my husband this morning or messaged him saying we're going to go for a ride tomorrow morning. So I think
Oh
like
yeah.
getting outside. So like if I like I love to travel, love to do things, but most of my things I like to do are outdoors. So
Mm.
I like going for a bushwalk, going for a ride. Like I usually prefer mountain biking because like you get to on trails and get to go out to like nature and stuff's my kind of thing. So I think probably my interest is, getting outdoors to nature and stuff. And we started doing a few of the multi-day walks. So
Oh yes, great.
I did the three Capes in Tassie
Mm.
most recently, and it was amazing. So I think I'm now a bit addicted that I'm now looking at all the walks I can do around and trying to prioritize which one I want to do next. So I think
I,
that's my next non-work activities.
I get the impression that Canadians are very good at doing that. I imagine it's from probably those long winters where when the weather gets good, any opportunity to get outside, you do.
Yeah, that's right. I'm from a tiny town. Well, so for concept, the town I'm from is about 1,800 people.
Yeah, wow.
So really small, but it's in the middle of a forest. So
Yes.
there's not a whole lot to do in the town. There's like, yeah, very little there, but there's lots of walks and paths for bikes and stuff like that. So I think you grew up, that was how you entertained yourself.
Michelle, thank you very much for coming on to the podcast. For our listeners who are interested to follow your work or learn more about your research, where would you recommend them to follow that?
Yeah,
Find
no,
that.
I'm not, I'm trying to get better at Twitter. I'm not the
Haha.
best at tweeting. So that's something that I am working on. But all my research gets published on the University of Queensland. Like if you just search Michelle Smith UQ, my research page will come up.
Yes.
Um, and yeah, so obviously you can follow research there, but I'm aiming to get better at tweeting things as well.
Well, and again, to all our listeners, please do like, subscribe, leave messages on whatever platform that you listen to our podcast, just to be able to extend who we reach and get more people to listen to researchers like Michelle. Michelle, thank you very much for coming on today.
Great. Thanks so much for having me.